I would like to introduce a colleague, mentor, and friend, Dr. Jay Katz, and he's going to talk to you about some of the new treatment options that we have. He's at Wills Eye Hospital in Philadelphia.
Thanks, Ruth. Good morning, everyone. Thank you for coming. What a great turnout, and thank you to the Glaucoma Research Foundation. I think this has been a hit so far, and Ruth gave a wonderful kind of intro to glaucoma. And I think all of you know the bad news, glaucoma can blind people. The good news, we can stop that. And my job today is to talk to you a little bit about the medications that you all are using, many of you are using, and then talk a little bit about where the future holds. And this is a very exciting time for us in the area of drug therapy for glaucoma. Dr. Williams pointed out to you that pressure is a really important risk factor for glaucoma development and progression. And all our therapy, every single therapy you're going to hear about, medically and surgically, is designed to lower intraocular pressure. We know that's effective in preventing blindness. We have studies out there that have been done and have been confirmed by additional studies showing that whether you use medications or surgery, we can effectively lower pressure for extended periods of time, years. And in these studies that are followed for years, you can show that the visual fields, where you may have lost some of the vision, you can stop that progression by effectively lowering intraocular pressure. So we know how to stop the disease. The trick is to keep the pressure down. So I've shown you here two plants that were instrumental in treating glaucoma. And a lot of you are thinking about marijuana. That's on the right. But really, I'm showing you the first plant, which is pilocarpine plant, where the extraction from that plant in the 1800s was discovered to lower intraocular pressure by using eye drops. And that led to the development of eye drops for lowering intraocular pressure. So you see here a timeline of pilocarpine being introduced in the 1800s as an eye drop for lowering intraocular pressure. And then you see there are some drops like alpha agonist epinephrine was used as an eye drop. And then for many years, the next eye drop was beta blockers introduced in the 1970s. Then there was a flurry of excitement in the 90s during my career where there was an introduction of prostaglandins, alpha agonists, topical carbonic anhydrase inhibitors. But then there was a real lull for approximately 20-some years where we didn't have any good drug therapy that was new to be introduced in glaucoma. And you'll hear about some of the new drugs that have been introduced just recently, and a brand new compound was just introduced this past week. Well, how do these drops actually lower intraocular pressure? Well, it's simply either decreasing the production of fluid or helping the fluid exit the eye. The eye is a closed space. So by using drugs that either help outflow or reduce inflow, it's really that simple. Now, it turns out that we have great medications out there. In fact, they've gotten better and better over the past decades with different formulations, different packaging to reduce the frequency of administration of the drops, better tolerability. But still, if you look out in the community, over half the patients out there are using more than one medication. So you often need a combination of medications to adequately control the intraocular pressure. This is just a busy slide, but kind of summarizing for you all the different classes of drugs. And I apologize, it's very confusing sometimes hearing the generic names when you're really only familiar with the brand names, but there's so many brand names, I've kind of kept it down to just the generic names here for you. So you're showing here drops that improve trabecular outflow, and you'll see something called uveoscleral outflow. It turns out there are two pathways for the fluid in the eye to exit. And we have drugs now that work on both pathways, both trabecular and uveoscleral outflow. And then we have drugs that actually decrease the inflow that are listed here as well. So we have all those pathways that we can target. And again, just summarizing here for you the categories. So there are kind of three main categories here for pressure reduction with drug therapy. Now, knowing how these drugs work, we often try to maximize the complementary action of these drugs by using perhaps one drug to help outflow and another drug to decrease inflow to maximize the pressure reduction. When your doctor's trying to decide which medication to use to lower your eye pressure, these are some of the things that they have to consider. Well, you want a drop that really lowers pressure well. I mean, you want to reach whatever target pressure, the safe pressure they're trying to achieve. They'd like to do that with the least medication for a variety of reasons. But you also have to be aware of the side effects. There's no drug that's totally free of side effects. So everything you're going to use has some potential harm. So you're going to look at the side effect profile, look at the tolerability based on the examination of the patient. And unfortunately, cost issues are very important to determine for a lot of you in terms of what can be used. If something costs $500 a month, that may be prohibitive compared to something that will cost $5 a month. You'll see the dosing here of the various drug classes. Some range from being used only once a day in the evening or once a day in the morning, but some of them have to be used 2 or 3 times a day. And that has to do with the duration of the effect of the drug. So some drugs really work the whole 24 hours. And using it more than once a day doesn't improve the pressure. You know, sometimes you think it's a good thing, it's working well, I'll use it twice a day. It actually is detrimental to do that, and the pressure may actually go up instead of down. And the other drugs that have to be used 2 or 3 times a day, if you only use it once a day, you're kind of uncovered for a good portion of the day. So you really have to spread the dosage out over the course of the day. The side effects are different depending on which drug you choose. Some drugs really have cosmetic issues, a really red eye. If it's a little bit red, probably okay for most of you out there, but if it's really red and if you're really bothered in social settings by that redness, that can really hamper you in taking the drop. You don't want to be embarrassed by having the eye really red. Sometimes there are effects on the lining of the eye, making it really irritated. And some of our drugs actually have systemic side effects. Even though it's an eye drop, it can give you systemic side effects, in particular the beta blockers. Now, the most common drug class that we use in the real world are what are called prostaglandin analogs. And these include a variety of drugs out there: latanoprost, travoprost, bimatoprost. Brand names that you might be familiar with are like Lumigan, Travatan, Zioptan, are drugs that are commonly used. Why? Because they're really effective lowering pressure once a day. Systemically, they're very, very well tolerated. But there are some potential ocular or eye side effects. It can make the eye color darker, the iris in particular, especially if you're hazel colored eyes. They're the ones that are most likely to change. It can also cause skin darkening on the eyelids as well. The iris color change is irreversible. The skin changes are reversible if you stop the medication. And also something more recently that's been noticed, that you can lose some of the fat around the eyeball. And that's something that we've learned with common usage over a number of years. It wasn't necessarily something that was predicted for, but now we know that it can cause some loss of orbital fat, so the eye may be a little bit more sunken, or the lid may be a little bit lower. The second most common class of drugs that are used are beta blockers, like timolol. And we know this drug is really well tolerated on the eye. And again, it's often used just once a day in the morning. But this drug can have systemic side effects. So if you have asthma, if you have an irregular slow heart rate, that can lead to problems like an asthmatic attack, or having you pass out because your heart rate drops so low, and falling. And those are obviously serious concerns. The third category are two different drugs here, are alpha agonists and carbonic anhydrase inhibitors. Brimonidine or Alpha-GAN and topical carbonic anhydrase inhibitors are brinzolamide and dorzolamide, also known as Azop, for example, is a brand name. And these are really great drugs also lowering pressure, but you have to use these 2 or 3 times a day. And occasionally you will see patients that develop kind of an irritation on the surface of the eye, kind of an irritation in the lining, a red eye called conjunctivitis, or irritated lids, blepharitis, that really stop you from using these medications. Now, as I told you earlier, there's a lot of excitement in our area because there are 2 new drugs that have been introduced within the past couple of years. After intensive study and scrutiny by the FDA, latanoprostene bunod, which is a variant of latanoprost, one of the prostaglandins. Somebody very clever took the latanoprost molecule and they put a side chain on that molecule that donates something called nitric oxide. Nitric oxide has also been shown to lower eye pressure. So now you have 2 different ways of lowering intraocular pressure with this drug, 2 different mechanisms, which I'll show you. And then also another really exciting introduction has been Rho kinase inhibitors, notarsidil or Ropressa. And this lowers intraocular pressure by a brand new pathway through the trabecular meshwork, but a brand new mechanism that we haven't had before. And the last thing I want to show you there, within the past week, notarsidil and latanoprost, 2 very commonly used drugs now, have been put into 1 bottle. So it's easier to administer and get both drugs from once-a-day administration. So these drugs, latanoprostene bunod, the nitric oxide component, and notarsidil are working on the trabecular meshwork pathway by allowing fluid through more easily through some biochemical alteration of relaxing that tissue. Fluid gets through more easily and thereby lowers intraocular pressure. The side effects, through the clinical trials, we know that there's going to be there's always a plus and a negative, and the negative is understanding what the side effects might be with these new drugs. Now, it turns out that the systemic side effects are really almost non-existent, but there are some side effects on the eye. With notarsidil, the most common is red eye, which we see with a lot of our other eye drops as well. There are these very subtle corneal deposits which don't have any effect on vision, and they can disappear if you stop the medication, if you did stop the medication, so we're not worried about that. And sometimes you might see little tiny hemorrhages on the white of the eye, especially when you first start using. Again, these disappear and have no effect on vision. So again, not a bad side effect profile with use of this particular drug. And latanoprostene bunod, since it's similar to latanoprost except for the side chain, it really looks similar in terms of the side effect profile, with redness being the most common side effect that people notice. So all in all, it looks like the trade-off, getting good pressure reduction with really not bad side effect profile. But as you all know, glaucoma is really a kind of a tough disease to treat for the things I've listed here. And Ruth mentioned to you earlier. I mean, this is a chronic, slowly progressive disease, often asymptomatic when you first get diagnosed, hopefully. If you get symptomatic, you've lost a lot of visual field. We don't want to get to that point. We want to really get the treatment on board very early to prevent that loss of vision. And if you stop your medications, there's no obvious downside. You don't see any difference, and it doesn't make you see any better, obviously. So there's no reinforcement, immediate reinforcement to continue taking drops every single day. And we recognize that, and I think the education, you need to understand the purpose of the treatment and the benefit long-term of the treatment. And even Hippocrates knows that a lot. He taught us even back in ancient times that patients often don't take their medications, and you don't want to tell us that. We know that, okay? It's embarrassing to say, no, I didn't take any of the medicine for whatever reason. So taking that into account, there are things that we look for in terms of how do we improve your ability to take medication. And we know that you may prefer one drug over another after discussing the intent of trying different drug classes, the tolerability of drugs, the cost, the complexity of the regimen, the number of bottles that you take. And it is sobering to look at some of the statistics out there and looking at how well patients take their medications. And you'll see that over half the patients are really not really perfectly compliant and adherent with their medical regimen. And some of it is just the physical inability to get drops in. That simple act is not easy. I've had to put drops in my eye for an eye infection, and I really hear your complaints about getting drops in. It really takes practice and the proper technique. George Spaeth from my institution, my mentor years ago, showed that if you took one medication, you're pretty good at taking the drops. If you ask somebody to take 2 bottles of medication, well, it's not so good anymore. It really drops the adherence to taking the medication. So really showing us the complexity and the multiple bottle use really cuts down on the ability to maintain a regular schedule. So there are some fixed combinations, meaning there's more than one drug in a bottle. So these are the most common ones that are out there: timolol dorzolamide, timolol brimonidine, brinzolamide brimonidine. So this is known as COSAB brand-wise, Combigan. And the new one, I'm sorry, I almost left out here, is notarsidil latanoprost. That's the newest one that just came out in the past week. And that's a combination of the new drug, notarsidil, that came out within the past 2 years, and now combined with latanoprost, a drug that we've used for the past 20 years. So these are the combinations that are used out there, and the brinzolamide brimonidine is something that has been used as well for a number of years. So here's the data that shows how drugs can be shown to be effective in combination. So this is showing how the COSAP, which is the timolol and dorzolamide, is more effective than the individual components, and how effective that may be. And the newest combination, Rocklatan, is the brand name of notarsidil latanoprost. And this busy diagram is showing how, yes, this drug is exciting because notarsidil that helps with trabecular outflow, latanoprost helps the uveal scleral outflow, so 2 pathways. And there seems to be maybe some other effects here, reducing inflow as well, and lowering the venous pressure around the eye, which also leads to controlling pressure. So there are perhaps these other minor mechanisms that may be in place. So it's exciting that we're attacking different pathways and lowering intraocular pressure. And here's the newest one again, the notarsidil latanoprost, showing that compared to the individual components, having them both in one bottle certainly lowers pressure more than each of the individual components do. So again, making it easier for all of you to use your medications by putting 2 medications into one bottle. One of the other issues that we worry about is the preservatives in bottles. We know that preservatives are great to have in a bottle because it prevents it from getting contaminated with bacteria, which can be a problem. We don't want to introduce bacteria on the eye. So we've used predominantly benzalkonium chloride over the years as a preservative, as you see here in this slide. But we know that with chronic use of eye drops containing benzalkonium chloride, some eyes, not everybody, but some people do develop a problem with toxicity from that preservative, meaning irritation developing on the surface of the eye that can affect the patient in terms of having a dry eye exacerbated or having a red eye and other symptoms. There are some other medications out there that have perhaps a more gentle preservative. They include things like Purite, Polyquat, Sofzia, sorbitol. These are other ones that have been tried, but they're still preservatives, and they still may lead to problems, but perhaps they're more gentle than BAK. And then finally, there are medications that are in what we call unit dose containers, where you can actually apply drops without any preservatives, but these are in these containers that you see here that are also made for artificial tears for dry eye patients. And there are several compounds out there that you can get, not all the drug class, but some of the drug classes with this. So you put the drops in and you throw that little unit dose container away. It's a little bit more cumbersome, perhaps, and it's also certainly more expensive than the bottles that have BAK. But when you have patients compare preservative-free versus those that have a preservative, you see that all the symptoms we associate with, let's say, a dry eye are markedly improved with the use of a preservative-free glaucoma medication. So are there any other viable alternatives to using eye drops? I've told you that eye drops are great for lowering pressure, but as I've also told you about the difficulties in getting it in, getting compliance to be really on target. So is there some way to get medications in the eye to help glaucoma patients? So it's going to maybe help compliance, overcome some of the side effect profiles, and eliminate the need for benzalkonium chloride and other preservatives. So here are some of the ones that are really actively being investigated out there. I think they're all exciting in their own way. I've summarized the external ways of delivering drug here in this slide. Some people have tried sprays, and they're still trying it again, trying to get sprays on the eye, which limit the amount of medication. You don't have to put a drop in. And even in this picture, you can see, well, the spray is hitting the eyelid. So it's going to be a little tricky keeping the eye open and trying to get the drop right on the eye. Contact lenses can be impregnated with drug, so for drug delivery. So you can put glaucoma drugs into a contact lens and have slow release on the eye. People also have a version now of a ring. It's like a hula hoop that's impregnated, so you put it on kind of like a contact lens, but there's a big hole there. So the ring part is where the drug is, and it slowly gets released and lowers intraocular pressure. And punctal plugs are used for people with dry eyes to keep the tear film around the eye better. So some clever folks have now figured out how to put drugs into that punctal plug. So you put that right in the tear duct, and it slowly leaks out glaucoma drug that way. So these are external devices that are being investigated right now. There's also the ability to get the drug inside the eye. So you have some system of actually delivering the drug internally. So these are some of the exciting ways that people are now actively looking at and presenting some exciting positive information. So you can put impregnated polymers inside the anterior chamber, the front compartment of the eye, that slowly leaks out drug, and that polymer dissolves over a period of months or maybe years, and just needs to be replenished when it does lose its effect. Nanoparticles are also used now, so you get an encapsulation of drug material in these tiny little bubbles that you place inside the eye, and the drug slowly leaches out. There are also devices that have been developed that actually are put in different compartments of the eye that will release drug over a period of months or perhaps years in the future to keep the pressure down. So in summary, I think this is an exciting time for patients and doctors, and I'm a glaucoma specialist, obviously, and I'm excited about this, but I also had my father. I watched him as going through high school, where he lost his vision from glaucoma in both eyes, and I realized the impact it had on his life and our family. And so I'm excited that all of you hopefully will have great alternatives for lowering intraocular pressure with drug therapy, with new drops, new deliveries in the future to stabilize your vision. So I think these are wonderful times for us. Thank you. You can introduce Arson.
Thank you. No, thank you, Dr. Katz. That was terrific.